one thing that's very relevant is, all right, people say, Mike, that's you. So what? That's a one-off. Who cares? You know, it's you. What about me? What happens if I get my genome sequenced? What will I learn? So we went in. We've now looked at quite a few healthy people's genomes, but we went over 10 people's genomes just like mine with a fine-tooth comb to see what you can learn, what you would predict about disease risk. Because some people say, wow, Mike, you're going to get your genome sequenced. You're going to see all these things wrong with you. It's going to cost $1 million in follow-up tests. None of it will be meaningful anyway, blah, blah, blah. So I can tell you, so we went into these first 10. We've actually done more than this now, so the slide's a little bit old. We went in and we asked how many of them have changes that you should act upon. Okay, at least do a follow-up measurement. That's what I mean by act. It doesn't mean you're going to do surgery or what have you. And so we did that. We went in for these 10 people, 5 Asian, 5 European, and went through with a fine-tooth comb. And there were some recommendations by a particular group that said, if you have changes in these 57 genes, you should report back to the patient on those. So we did that, and it turns out, well, the answer is 5. There are, on average, 5 reportable things in each of these patients. Okay, median of 5, with the range of 2 to 6. And from these 5, it led to 3 follow-up diagnostic tests. Okay? Those tests, in sum, cost between $400 to $1,400. So I would argue not so expensive. Depends on your income, but that's, I would argue, not so bad. But I can tell you, one of those changes was, in fact, a BRCA1 change in a person, in a female, who did not have a family history of breast cancer. Okay? That information, I would argue, is worth the whole 10, because that person, in fact, did opt. They didn't have to, but they opted for surgery based on that information. They would not have known that had they not got their genome sequence. Okay, so I'm not saying you're going to learn something that's going to act. It'll tell you things that you do. It's like the telomerase for me. I do a follow-up test. Okay, nothing to worry about. That's fine. But if you do see something that you might want to keep an eye on, like a BRCA mutation, this is, sorry, I didn't say, but that's increased risk for breast and ovarian cancer. Many of you may know this. That's incredibly useful information. Even if you don't do surgery, you will want to get monitored at a much higher frequency than you would otherwise do. Okay, so this is, I'm not saying you will learn this, but you may learn this. And that's the kind of information you could learn. And I would argue at least for that person, that's invaluable information. Okay. It's not easy to do this. There's about 100 variants you look up, and it takes an hour per these changes. This is a lot of work. This is why it's $3,000 to sequence a genome. It's actually $15,000 to $20,000 to interpret it. Okay, it's a lot of effort right now. That'll go down, especially as the database grows and we get more automated, but we're not even close to that right now. Okay, so this is my future. This is what I would like to see. This isn't everybody's future. Okay, this is the future, though, that I would recommend, which is to say you will get your genome sequenced or have the option. You'd probably get your genome sequenced, I would argue, and you'd probably do it before birth. That is, while DNA is still circulating in the blood. There are actually measures for doing that now. It's not done for whole genome sequencing, but it's done for chromosome abnormalities. You'll get your genome sequence. I would argue you would have a lot of other information collected as well. Forget these 15 analyte tests. Let's get thousands of things. I don't know which thousands they will be until we have a lot more research. But I think from the millions of things we're measuring now, I hope that'll turn into hundreds or thousands of useful things that will be useful for measuring disease. We'll bring in other sorts of information as well. I don't think I'll get to this today, but we're doing all kinds of other measurements on me and other things, all the steps I take, all the biking I do. And I want to integrate all that sort of information. I want to have an automatic electrocardiogram on me. Right now I do it periodically, a couple times a day. I'd love to have it automatically sensed. I want to have all that information to be able to collect it and combine it with the molecular data and really ultimately understand how this can be predictive for disease states. I'm not saying that's a research project, by the way, not a medical, clinical project. But the ultimate goal would be to predict, oh, I forgot to say, in my world, these molecular tests would be set up as little home assays. Because as a healthy person, I don't know about you, I used to go to the doctor every 2-3 years. If we did that for my diabetes, we would have discovered it 20 months later than we did. That would have been way too late, in my mind. And so I would argue we need frequent home tests to be able to measure this sort of thing. And so the ultimate goal will be to combine this information. And it's not going to get rid of doctors. Don't get me wrong. It's going to do the opposite. It's going to leave these tests that you'll go in and do follow-up if you see something that you should be following up on. Again, this is my world. Now, I would argue not everybody should get the information returned back to them necessarily. Some parents are real worriers. They might actually do more harm to their kids by over-worrying. But I would argue minimally you would get, you may not know this, but there's about 70 genetic tests that are done on every child that's born right now. Okay? PKU is a standard one. Because if you catch that early, you keep them you change your diet. So that information would instantly go back into the medical care for that individual. Other things would just be put in store that if something popped up, the doctor, or actually would argue a genomicist, would look at that information and then decide whether, oh yeah, there's just like the kids with dystonia. Something's wrong. Well, let's see what's wrong in there. Let's see if we can figure out what's wrong. They'd have that on record and then try and bring that in. Okay. If they don't need it, great, it just sits there. And then in the future, you would certainly use it for the drug stuff. There's all kinds of other challenges associated with this. We're working on other methods for bringing other sort of environmental factors. I mentioned that we're bringing all kinds of other information I think will be valuable as well. This is a so-called quantified self. Follow as many parameters as possible to see if we can correlate human physiology with molecular markers with health states. That's the ultimate goal. This is going to be a very information-rich. I don't know how many computational people are here, but just for me, this first 14 samples we studied was 50 terabytes of data. Okay, so very quickly when we finish this next round of 60 samples, we'll be at about I think it's about a petabyte of data that we'll have, especially with the microbiome. That's on one person. Okay, so but luckily the field keeps moving forward, and hopefully some of you will figure out how to solve the data management issue. All right, I see we're at the end of this, so I'll just leave this in conclusion to say that genome sequencing, it's not 20 years away. It's now. You can get your genome sequence now if you want to. Again, it's not for everyone. If you're a worrier, you shouldn't get your genome sequence. Okay? I would argue that at some level it can predict disease risk. I would argue it's still early days, and we'll be able to do this 100 times better, probably 5 years from now, but we can still learn something now. I would argue bringing these other omics technologies will be very, very useful and hopefully ultimately give us a better sense of predicting disease risk. I think the most important part is here in the next slide. Every person's profile is not the same, just like cancer. That we all have slightly different profiles, and I think this is why it's really important that you get your own, especially now at baseline, trying to understand what your healthy profile looks like. So when you can see your change, this is what a lot of people say to me, Mike, you only did this on one person. I say, well, that's okay, because I want to see how my healthy state, how my state changes relative to my healthy state. No offense, but I don't care how my disease state compares to all of your healthy states. That's hard for me to interpret. But if I have a baseline healthy state, I can see how this changes at a level no one's looking at. And again, at a level that I hope will manage my health. And this leads to the last part. I think ultimately you will be responsible for your own health, just like the dystonia kid's mom. That is to say, there's too much information. You're probably seeing this already. When you get information back, your doctor has 15 minutes to give you some advice. See the information, make an assessment, give you the advice back. And that's probably accurate. That's not an over-exaggeration. You have hours, and will spend hours thinking about this and talking to various people, and ultimately you will have to manage this information appropriately and seek it out, and there'll be others to help you as well. I think the physician of the future will be a coordinator of healthcare, not a dictator of healthcare. That's a biased opinion, okay? And so lots of people helped the project I've mentioned from our lab, and so a large team, actually, more and more people just jumped in. I said, great, the more the merrier. I still get lots of free advice about my DNA and health. I always like to thank my mom, who was a good sport in this whole study, because I can definitely say that without her, the study would not be possible. So I think we're at 7:05. Sorry to go a few minutes over, but I'm happy to take questions if you have any.
Hi, everybody. Thanks for using the mics in the back two corners of the room here if you have a question for Dr. Snyder. Thank you.
You want me to start?
Sure.
So I have a question. Very interesting talk, by the way.
Thank you.
Could you comment on the compatibility of the kind of healthcare you're promoting in the upcoming Healthcare Affordability Act?
Yeah.
And then I have a second, more technical question.
Yeah. I mean, realistically, what I'm talking about right now is a research project, obviously. Because I think what will ultimately be a clinical test will, in fact, be some subset of what we're doing. We just don't know what subset that is. And that's the reason we're collecting billions of measurements, because I don't know which ones of those are most meaningful for diabetes, for prognosis, for all kinds of things, for cancer, schizophrenia. What I do know is that someday I will die of something, and I think there will be some markers before that happens that I hope, if it's a slow phase, that I will be able to figure this out. If it's an acute thing, then maybe someone after me will figure this out. And I will also argue that 1 million of these profiles will be extremely valuable for extracting that sort of information. So again, right now, it costs a fortune to do this. I believe that a test could be set up for a few $100s to do this, actually, not the level we're doing at a much cheaper, a much lower resolution, not billions of measurements, but say that. In fact, we're working on this right now. We have a very simple pinprick assay that'll measure 1,000 things in your blood. Okay, that's already over an order. It's almost 2 orders of magnitude what we're doing now. So, and that won't cost very much. So, I think it can be done cheaply. Economics are a very tricky situation. I think many people have made arguments just from the genome sequencing aside that it is useful to sequence people at risk for cardiovascular disease, because you make you can make an economic argument that if they have a stroke, they'll go into long-term disability, which is extremely expensive. And so most of the modeling studies say cardiovascular is a great way to get started in this area, because if you sequence them, you actually save money. Cancer is a no-brainer, quite frankly. It's going to be standard of care within a few years, because there's no sense throwing these expensive drugs on people who have no chance of responding to them because they don't have the right genetic makeup. And so that's just a complete waste, and so people use that as an argument for saving money. Now, the models are very complicated for doing all this, but there are certainly some ways you can argue it's being done right now. Right now, though, for these mystery diseases, it's very common to actually get reimbursement from most insurance companies for kids, because if they're going to 100 hospital visits, that's very expensive. So again, some of these areas, it's a no-brainer. And this is typically how these things roll out. That is to say, the people who need it the most, who would save the most time and who will save the most money for an insurance company to pay, will get it first. And unfortunately, it's a reality, but that's how it is. Then I think as people show that this works and proof of principle, more and more will get it probably. And I think that's how it's going to roll out. So it is being incorporated now, I would argue. Healthcare Affordability Act, that's a whole separate discussion. So we can do that later.
Can I ask a quick second question?
Okay.
So this goes to your simple assay format. The last prognostic test that I'm aware of that got approved went through 10,000 patients for a colorectal cancer prognostic marker. So I was wondering if you're aware of the problem with multiple test correction and the billions of markers you're looking at.
Oh, yeah. We did Bonferroni correction on all these. I obviously didn't get into that kind of tech, because we're measuring 40,000 molecules in that first. So we have to find pathways that are actually changing that would actually be past that correction threshold. So
I was just curious.
We did account for all that. Luckily, I was very fortunate timing. I had a physicist join my lab at the time we launched this project, and he basically took control of the whole statistical analysis. So the point you're raising is a very important one. It's one we've taken care of. Yeah, hi.
Hi, thank you for a great talk. So you mentioned that for the microbiome, you're taking samples from 5 places on the body, and I was just wondering, there's a general trend in medicine to assume that human equals male, and women are complicated and have messier data, so let's not measure them. And so I'm wondering, did you consider taking a 6th microbiome measure for women on the philosophy that it would probably yield all kinds of useful health information? And,
well, I would argue we're not too worried about gender for us. As we roll this out, the next phase is to roll out a study with 50 people, and we hope to take 25 women and 25 men. So we will see gender changes probably at many different levels, not just the microbiome. And yeah, if the point you're raising, are we doing vaginal swabs for that microbiome?
Polite way to ask.
It's a good point. We probably should be bringing that in. We haven't done that yet. We literally got funded. It was just announced yesterday
Oh, wow,
for this. So we're
congratulations.
only about to start enrolling patients now. So I do think that would probably be a good one to add to the mix. So maybe we'll do 6 for women.
Thank you.
Question relative to your rapid onset type 2 diabetes. You also expressed that maybe we don't really understand it that well, and there are a lot of causes and variations and so on. I wanted to ask if perhaps you considered that you may have actually treated it, and you no longer need to maintain the diet and exercise regimen that you're currently maintaining in order to keep your glucose levels there. And did you try, or you could try increasing your sugar intake and seeing if it doesn't have any effect anymore.
Right.
So it might have been a transient effect. This
Yeah.
type 2 diabetes, which was triggered by the virus, might have been transient, and you treated it, without medication.
Yeah.
Because one of the things I've seen in medicine has been that a doctor will make a diagnosis of some condition and prescribe medication, especially in older patients, that they carry on for the rest of their life. And maybe they need to be taking that medication for the rest of their life, but maybe they don't. And so this might be, something that, a different way of treating disease states.
Yeah, what you've suggested has not escaped my attention. That is to say, and there, almost inadvertently, I've let my statins run out about 6 weeks ago. So that's one experiment I'm doing, and I'll see how that correlates with glucose levels. That's the advantage of taking lots of. I actually do think that would be an interesting study that you're proposing. I'm not quite prepared to do that yet, but we probably, I may do it at some point on a transient level. We have a different study we're doing with someone at Stanford as well, who's very interested in people who gain weight, and we're actually doing some direct correlations with them in a better controlled experiment. So for the moment, that's the avenue we're pursuing, but whether we do this on me at some point, it's possible. And what you say is absolutely true on drugs. People don't know. Nobody ever wants to be the control, though, where you come off the drug and then obviously an adverse event happens.
Yeah, I mean, you have to do the continuous monitoring, and that's the expense.
Yeah, if you're
part of the
doing very
equation.
frequent, you could
Yeah.
probably catch it right away. That's right. And so there's a possibility we'll do it. The odds of the number one risk for diabetes is age. So the chances of this coming back again are very high. I expect to correlate it with some sort of stress response. And there was a little bouncing around last winter. The adenovirus infections aren't so calm either. Rhinoviruses are very mild. Adenovirus is a little severe. So we'll see how that all plays out. But I didn't have anything go off scale like I did the first time. So, I mean, you're suggesting something reasonable, sort of.
I was a bit troubled about the concept of a reference genome. I understand you have to compare to something, but as you point out, even James Watson will have 3.7 million SNVs in his genome, and if he's the reference, or he and 22 of his best buddies, are the reference genomes being updated on a regular basis?
Yeah, well, first of all, there is no complete human genome sequence. There are problematic regions of the genome that have never been properly covered. So people are working to fill those in. The reference genome is a complicated issue because you're right, nobody is the perfect genome, and we all have these hundreds of rare alleles that are damaging, that are damaging our genes. And so, but it is interesting because what you say is very true. When you compare your DNA up to a reference genome and you're matching somebody else's disease gene and you say, well, I have the same as the reference, that doesn't mean you're in the clear. So people are going through this to see which ones are associated, which ones are damaging in the reference, and deciding on what's a medically, so there are about 6,000 medically relevant genes now. I mentioned 4,000, but there are drug response genes. There are about 6,000. People are poring over this to be able to see which ones are associated with what, and then in the reference know what's what. At the end of the day, what you do is you really correlate all these alleles, but now there's 1,000 people have been sequenced, and people actually match up their changes relative to this 1,000 and see how they compare that way. But then they also look at the 6,000 genes to see which ones are really inactivating and which ones aren't. So it is a complicated issue. I don't know if that's completely clear, but you're hitting a really very, very important and non-trivial issue.
And in the beginning of your talk, you mentioned 3 types of mutations. Where would you classify copy number variants? Under structural?
We all have these numbers. I mean, we all have 3,000 structural variants of 2,500 bases.
No, I was
or
thinking
larger.
about copy number variants that would associate with things like autism and so forth.
Well, again, yeah, how many of those are, see, autism hasn't been so well worked. I mean, we think autism is hitting pathways, as do other groups. And so it's mutations hitting a set of genes probably responsible for that. And that has not all been worked out in a nicely predictive fashion, unfortunately. Although I think as we get more data, it should be. So what's a healthy, we don't know the answer to what you just said, actually. I guess that's the bottom line.